My interest in this first started 22 years ago when the Department of Health, working with the NHS screening unit, invited me to develop some resources specifically for women with learning disabilities to access breast and cervical screening. And this was because the take-up of screening for this group was so poor. The report was called Good Practice in Breast and Cervical Screening for Women with Learning Disabilities. And re-looking at it today, so much is still really, really relevant. The materials, the guidance came as a traditional NHS publication, but it also had a leaflet and pictures for women who found pictures easier than words. And it had 2 picture books. All were created jointly with women with learning disabilities as advisors and storytellers, and indeed authors of the books. And the aim of the screening materials was, as you would expect, to ensure that where possible, women have access to information to help them to make their own decisions about whether or not to accept an invitation, but also to know what to expect when they attend for screening and to understand the possible consequences of screening. And what was fascinating while the materials were being trialled was that the women who met together in groups to discuss it started going during the life of the project to experience screening for themselves. So at the time when screening uptake was so poor, we discovered a number of things. One, for example, was that often health professionals and carers took the view that, for example, women with learning disabilities wouldn't be at risk of cervical cancer because it was assumed that they were not sexually active or indeed would not have had any sexual experience, including abusive sexual experiences, which of course is not true. So one question I have is what progress has been made since that guidance was published in 2000, and also whether GP learning disability registers may have helped with increasing the uptake for those people who choose to be registered. First, though, I want to consider the inequalities that people experience. And I can't really do this without thinking about Oliver McGowan, and I'll say a bit more about Oliver's story in a moment. Also, it matters even more so during the pandemic. There was a report in 2008 called Healthcare for All. And one of the findings was that although we have good laws in place, they're not really implemented adequately within public services, including within the NHS. So we need to understand the law and how it relates to healthcare practice. We all need to know how to make reasonable adjustments, what they are, and to understand that they vary for individuals. And I'm going to introduce you to resources which I've produced with my charity Beyond Words. So here's the independent inquiry into access to healthcare for people with learning disabilities, and it was chaired by Sir Jonathan Michael. I was a member of the panel. Sir Jonathan Michael was a physician, a senior physician, and I must say he was completely shocked when he discovered how, even in his own hospital, people with learning disabilities were not getting equal access. But the stimulus for the report and the investigation was to see if the problems raised in MENCAP's very important report, Death by Indifference, were widespread. So some of the things that were found were that, for example, staff knowledge and attitudes were poor, that there was too little training for staff, and that despite the law, reasonable adjustments were not being routinely made. So good practice was there, but it wasn't universal. So sometimes the barriers are barriers which really are within the power of health professionals to sort out, to really understand what's worrying the person, the patient, and to explain properly and in an accessible way. We've seen during the pandemic that blanket DNAR orders were being used at some points during the pandemic. But something which has continued for a very long time is the phenomenon of diagnostic overshadowing. And basically what this means is that a person presents with a symptom and it's erroneously assumed to be part of their learning disability or their emotional behavioural response to their learning disability. And I know from my own experience with my son, who has a learning disability and he's an autistic man, when he had a very high temperature on one occasion, it had been assumed that his behaviour was due to anxiety or something connected with learning disability. But when I visited him, having been concerned about the story I'd heard, I found that he'd got a very high temperature and he was actually delirious. So it's quite easy, if you don't know a person well, to mistake the experience they're presenting to you as being due to something else. So Oliver McGowan very sadly died because of really a failure of the health professionals who were treating him to attend to his needs, to listen to him carefully, to recognise that he knew something about himself. His parents have set up a very good website. It's worth looking at if you haven't. And they have a number of asks on their website. One of the most important things is that you should put people at the heart of all decision making and respect them, and that you should enable them to really understand complex decisions in a way that's relevant. And of course, all of this within the context of the law. The request for mandatory training for all health and social care staff has been discussed and debated for a very long time, but really because of Paula McGowan's advocacy and other people's work in supporting her and calling for mandatory training, this is now being piloted. So what we know is that people with learning disabilities have a much higher rate of avoidable and premature mortality, i.e. they die younger than other people of the same conditions. In 2019, the National Mortality Review, LEADER, reported that people died on average 25 years earlier than the general population. Now, during COVID, during the first wave, from the data that Public Health England has analysed, the overall death rate for people with learning disability was estimated to be up to 6.3 times higher than the general population. This is important because the vaccination prioritisation is decided by age. Over 65s are much more likely to die from COVID than under 65s. The problem is that people with learning disabilities are dying younger and not reaching 65 in ordinary times. So in the general population, only 8% of deaths are from avoidable medical causes, whereas 1/3 of deaths of people with learning disabilities are considered avoidable. And these are some of the most consistent reasons, and this is why it's so relevant to us today. A poor uptake of screening is obviously really, really relevant to us. But other issues such as delays with diagnosis or treatment and problems identifying needs. So one of the requirements within the mandatory training really is that experts by experience, people like Gary Butler, should be involved throughout the development, training and delivery of services. And I'm just going to show you a short clip from a film about Gary's experience.
Doctors are usually pushed for time, so they've got to get in, explain the procedure as quickly as possible, but in doing that, sometimes muddling the patient. So we get you to tell us what's going on in the picture. In other words, you tell us your own story, what you think is going on. Okay. Now you find out what the books behind words are all about. Pictures without words. But most of them, there are guidelines at the back of the books for staff and support workers. The book takes it in stages. How to approach a patient, how to explain something, depending on the procedure being explained. So like taking one's blood pressure, for example. There's one book where you could use for that particular procedure. Giving the patient a book means that for that moment in time, the patient has the ownership of the book, and it's quite self-explanatory in the book on what's going on, and the patient can actually follow what's going on just looking at the book.
It made me feel reassured. When you see the picture, you know it's something you do on an everyday basis, don't you? Take people's blood pressures, temperatures.
A quick summary of the law. The Mental Capacity Act, we have to remember that capacity is assumed unless we discover that the person does not have capacity. And in the event of somebody being assessed as not having capacity to make this particular decision, then best interest meetings and best interest decisions should be made. I was involved with the Post-Legislative Scrutiny Committee for this Act in the House of Lords. And although it's an empowering Act, overall a good Act, it's not understood adequately and not implemented adequately. And the National Mental Capacity Forum, which is chaired by Baroness Elora Finlay, is doing very, very good work now to try to really increase the appropriate use of the Act. The Equality Act requires services to attend to the needs of people with protected characteristics, and very specifically, this involves making reasonable adjustments so that people are able to access a service fully. Jim Blair, who has created this acrostic called TEACH as a way of trying to remember how to make reasonable adjustments. I've adapted it slightly here. But the important elements: taking time to work with the patient, adjusting the environment if it's needed. Typically that might mean a quieter room without distraction, maybe lower lighting, less noise. Being really positive and avoiding diagnostic overshadowing. Listening to the patient and using pictures or other communication aids to support you, but very particularly finding out what this particular patient needs in terms of communication. Quite often it involves really taking time to allow the person to process a question, not to keep repeating it, but to give them time to think and to respond in their own way. And then making sure the right help is there. If, for example, they need to be there with a supporter or carer, making sure it's the right supporter or carer who's present with them. People themselves, their supporters, carers, professionals often struggle to explain their symptoms in a shared language, and the people themselves may not understand why they might need to check things out. There are co-production standards for easy read information. I put a link here. I'm sure people on the call are very familiar with the accessible health standards. And these are very specifically around easy read. Is an example. And you can see easyhealth.org, where there's a very good collection of easy read information covering a number of different conditions. And PEC's Picture Exchange Communication System, some people are very familiar with. Big question, can pictures help? There's quite a bit of research to show that they can. And there are many people who really struggle to decode words at all. So even with easy read, there are some people who find easy read really daunting. My son's one of those. If he's presented with something, even with pictures in it, if there are words there as a non-reader, he won't attend to the message which is included. And that's why I ended up creating little stories to try to explain in pictures. So here's another video, and it will share a little bit of background about how and why pictures help.
They're aimed at people who find words difficult and who may find pictures easier than words. And they're designed as a communication tool, as a way of helping people to understand things which might be difficult to understand in words for them. They are mainly used by people with learning disabilities, usually with a supporter, a friend, a relative, a professional.
So Beyond Words creates wordless stories for a number of reasons, a number of purposes, depending on the story and the circumstance and who's reading it and who they're reading it with. Supporting decisions is very important, obviously. Checking for understanding, explaining a procedure, and here we see somebody having a mammogram. We did a study to try to evaluate the use of pictures instead of teaching delivered by a learning disability nurse. Both conditions were very successful. There were 36 allocated to a teaching group, 37 to a pictorial leaflet group. The leaflet group were given a leaflet to take home and to share with somebody they knew. And it was fascinating because they all significantly improved their confidence in being able to check, to seek help. The leaflet group took longer to achieve those outcomes. They were all invited to keep a diary, to consult their GP if they were worried about something. And all of them reported regular testicular self-examination during the 6 months of the intervention. So that was very encouraging. After developing our easy guides to breast and cervical screening, we were also invited to develop one for bowel cancer screening, which is shortly to be updated. These leaflets are available from NHS screening unit, the National Screening Unit. Here are some other free resources that we've developed to support people through the pandemic. And we were able to do these very quickly because of the artists we work with, and just an extraordinary commitment to try to get there. You'll see that it includes having a vaccine for coronavirus. So we know that COVID-19 is particularly prevalent in congregate settings, and this is true of prisons and secure hospitals too. So Beyond Words created a story and toolkit for prisoners who might find pictures easier than words. And the story now also includes a vaccination hesitancy story with an encouragement to prisoners to consider agreeing to vaccination too. The quickest way to find Beyond Words stories is through the BW Story app, and it's searchable and includes most of the materials I've spoken about, including the screening leaflets and screening stories. And it becomes a very easy go-to resource to help you communicate when you suddenly realise that the person in front of you hasn't understood what you're discussing with them. One of the things about pictures is that you can actually ask the person themselves to tell you what they think is happening in the story, rather than using the pictures simply to tell the person. They're not so much about sharing information, but about really checking for understanding. So I hope that in this very short talk that I have covered a range of issues which interfere with people's ability to engage with screening, the kinds of things which lead to health inequalities, which lead to vaccine hesitancy, which lead to a poor uptake of the national screening programme opportunities, and that by perhaps bringing people together in wellbeing groups, which can be face-to-face or online, and during COVID there have been quite a number of people, organisations, bringing people together online to be able to discuss health opportunities, health anxieties, health outcomes with their peers. That this in a way is simply mirroring the way that most people in society address their health worries, using whatever resource is available to them and accessible to them, whether it's by searching on the internet or just talking to a friend or asking or finding some other way to inquire directly from a health professional. We have a health system which requires you to be proactive. And it's very difficult to be proactive sometimes. If you don't have the language, you don't have the opportunity. So our awareness of that and our awareness of the need to get on the same page with our patient in order to be able to really truly give them full access matters.